All right, and that is 7 p.m. So I'm going to go ahead and get started. First of all, hello and welcome to everyone. My name is Nicole Levinson, and I am with the Anchorage Public Library. We're here today with the Anchorage Health Department's Dr. Bruce Chandler for our first What We Know as part of the Vaccine Information Series. First, I would like to give our land acknowledgement and acknowledge that the original inhabitants of this area are the Dena'ina people. The land that Anchorage is situated on is the traditional and sovereign unceded land of the Dena'ina. We honor with gratitude the land itself and the Dena'ina people, past, present, and future. Today we're going to be talking about the COVID vaccines. But before we jump in, first let me go over how this program will be run. All participants except the presenters will be muted during the entire presentation in order to prevent confusion and everyone speaking over each other. First step, Dr. Chandler has a presentation prepared for us, which he will give about COVID and the vaccines. Once he is finished, we will open the question and answer portion of the program. If you have a question you would like us to answer, please post it in either the Teams chat or in the comments on Facebook Live. We do have a staff member monitoring both the chat and the comments, and they will forward your questions on to us when we reach the appropriate section of the program. If we do not manage to get to your question before the end of the program, we will do our best to answer in the comments afterwards or include it in our next section of the program series. Now that we have that all out of the way, Dr. Chandler, if you would like to go ahead and start your presentation.
Okay, can you hear me okay and see my slides?
Yes, we can.
Oh, good. Well, there's some cats running around here. They may interfere with the presentation. So I was asked to share some information about the COVID vaccines. I start first with a little review of what we know about COVID. This is a coronavirus that spreads very easily from person to person in close contact. We've seen very rapid spread in residential facilities and in family groups. So very highly infectious from one person to another. What's interesting is many people have no symptoms but may be highly infectious. The estimates run as many as 40% of people who get COVID have no symptoms, but still are infectious to others. And CDC estimates that more than half of all the COVID infections are due to transmission from people who have no symptoms. So it makes it very difficult to interrupt transmission when there are people in our midst who feel absolutely fine, but they may be spreading the virus. Infection with the virus can result in a range of illness from very mild symptoms, actually to no symptoms, to mild symptoms, and a few people get very severe illness and die. We know there are trends where older adults and people with certain medical conditions are at increased risk for severe illness. But it's hard to say with any certainty how it's going to affect any particular person. Most of the people who die have underlying medical conditions and are over 65 years of age. This is the list of medical conditions known to be associated with increased risk for severe illness. This is from an Epi bulletin by the section of epidemiology. It was published in October, reviewing how different age groups are affected by COVID. And as you can see, the older the age group, starting at about age 30, the rate of hospitalizations steadily increases. And when you get to be in your 70s and 80s, it's a very high rate. This is a similar figure for the number of deaths in Alaska through October 15th, sorted by age group. And again, you see after beyond age 60, there's a marked rise in the number of deaths. And also that many of those people who died in their 70s and 80s had medical conditions that also put them at risk. So many young people don't have these risk factors and usually have very low rates of severe illness requiring hospitalization and ICU care. But on occasion, some of those people will go ahead to develop the severe illness that we worry about primarily in older people with medical conditions. At the time of that Epi bulletin, there had been 67 deaths among 10,564 cases. So that's about one death per 158 cases. As of this week, we've had 229 deaths among 50,000 cases. So the death rate's dropped a little. It's around one death per 220 cases. Some of that's because we're seeing more illness in younger people who aren't at great risk, and also there are more treatments available to treat people when they develop symptomatic COVID or if they require hospitalization. Severe illness with COVID isn't equally distributed among all racial groups. The white population has had a very low rate of death. American Indian, Alaska Natives, Asians, and Black populations have higher rates of death, and the death rate has been extremely high in the Native Hawaiian and other Pacific Islanders. So moving on to vaccines. I'm sure you are aware we currently have two vaccines approved by the FDA for use to prevent COVID-19. These are both messenger RNA vaccines. They both require 2 doses for maximal protection. About 1 month ago, the first vaccine, the Pfizer-BioNTech vaccine, was authorized. That one's approved for persons 16 years and older. This is a 2-dose vaccine given 21 days apart. For people who complete the 2-dose series, it's been found to be 95% effective at preventing COVID-19 infection, starting around 7 days after the second dose. They didn't find any serious safety concerns with either vaccine in the trials. The Moderna vaccine is very similar. It was approved, because of how it was tested in the trial, it was approved for people 18 years and older. Also a 2-dose vaccine. This one was the trial involved second dose at 28 days, so that's how it was approved. And again, found it to be 94% effective after 2 doses. Just a short review about messenger RNA vaccines. So a long time ago, in February and March, after it was identified that this new coronavirus was causing illness, the scientists went to work and they were able to um, sequence the genetic code of the virus, and they were able to identify different segments that coded for different proteins in the virus. And the one of particular interest was what's called the spike protein. And that's the protein on the surface of the virus that allows the virus to bind onto cell walls and gain entry into cells so they can replicate and produce more virus. So since last March, that's been the primary target, these spike proteins, to develop an immune mechanism to produce antibodies to bind to the spike proteins so the virus is unable to bind to cell walls and enter into cells and replicate. So in the months since last March, the scientists have developed, identified the segment of the RNA code that codes for this spike protein. Let me say that again. So we've identified the messenger RNA that codes for this protein. And then it's being purified and then coated with a lipid or fat coating that allows it to move into cells. And then when it gets into your cells, it produces this spike protein, which is released onto the surface of the cell. And then our normal immune system detects the protein, and our immune system reacts against it and produces antibodies, and we get both antibodies and T-cell immunity against the virus. It's important to know messenger RNA vaccines do not contain live virus, and they will not cause us to develop COVID infection or illness. This slide's about the two trials that were done that were finished in October and November on the two vaccines. They enrolled very large numbers of people into their trials, 43,931 in the Pfizer vaccine and 30,000 people in the Moderna vaccine. They included a good population of older people in both trials and a good variety of different racial people of different races in each trial. And so in the trials, people were given a dose of vaccine, and then for the Pfizer vaccine, they were given a second dose 21 days after the first dose, and the Moderna trial, second dose 28 days after the first dose, and then everyone was monitored for the next a total of 4 months, and observed closely to see if they developed symptoms of COVID over that period of time. In each trial, half of the people that were enrolled received the actual messenger RNA vaccine, and half of the people received a placebo injection. And every participant didn't know whether they'd received the real vaccine or the placebo until the study was completed. So this to me is a fascinating figure from the Pfizer BioNTech vaccine. On the bottom x-axis, we have days after our first dose of vaccine, up to 119 days. And then on the y-axis is the incidence of COVID-19 among the people who are participating in the trial. These blue squares are people who are in the placebo group, who received the placebo vaccine. And we see over the 4 months a steady increase in COVID-19 among the people who received the placebo vaccine. These red circles are cases among people who received the actual vaccine. And right about here at about 10 days, they've got a magnified view up in the upper left. Right here at about 10 days after the first dose of vaccine, before the second dose even, we start to see the number of new cases really flatlines among people who received the vaccine. And that really continued at very, very few cases among people who received the vaccine for the duration of the trial. This is the corresponding figure for the Moderna vaccine. It may be less easy to see, but again, right here at about 10 to 12 days, we just start to see the line separating and very few additional cases in the people who received the Moderna vaccine, even one dose. There's a lot of discussion whether maybe over how much protection people would get from one dose alone. And they're still examining that issue to see, but at the moment, the recommendation is we all should get 2 doses when we're able to. There are certain people who should not get the vaccine. The primary people who should not are people who have a severe allergy or anaphylaxis to a COVID vaccine or one of the components in the vaccine. I'm sure you've probably heard or read that some are on rare occasions, people have gotten an allergic reaction to the vaccine. Some of the thought is this polyethylene glycol component in the lipid coating around the mRNA may be causing some of those reactions. But anyone who gets a reaction, if you get a reaction to your first shot, that's it. We don't want you to get another dose. Or if you have a reaction to any of these ingredients, you shouldn't get the vaccine. Right now, the vaccine is not approved for under 16 years for the Pfizer vaccine and for under 18 years for the Moderna vaccine. This is a figure from CDC, kind of a summary sheet on who can get vaccine and who shouldn't. Again, anyone with a severe allergic reaction to any component of the vaccine, we don't give further vaccine. If you've had a severe allergic reaction to another vaccine or another injectable, that's on a case-by-case basis. Depending on what you and your medical provider and the vaccinators decide, you can consider getting the vaccine. But if you do elect to go ahead, we want to watch you very carefully for 30 minutes after you get the vaccine. For less serious allergies like pet allergies or bee stings, food allergies, you can get the vaccine, but again, with that history of allergies, we like to watch you for 30 minutes. We'll talk, other conditions we'll go over in a minute on immunocompromising conditions, pregnancy and lactation. We'll go into those a little more detail in a second. So this is a simplified view. If you have a severe history of anaphylaxis due to any cause, we like to watch you for 30 minutes just to make sure nothing serious appears in that period of time. Everyone else we watch for 15 minutes after we get the vaccine. They haven't tested to see if I get a Pfizer vaccine for the first dose and a Moderna vaccine for the second dose, will I get a good immune response, and vice versa. So the recommendation is to always complete the series with the same vaccine that you started. If something gets screwed up, however, and you happen to get one dose of each, they don't recommend giving any further doses. We get a lot of questions from people who've had COVID and whether they really need to get vaccinated. We know that many people have some degree of protection for at least the first 90 days after their initial infection. At the health department, we've had a few people who've had very likely second confirmed infections in the third month after their original illness or shortly after completing their third month. So we know that some people don't get long-term protection from their original illness. So the recommendation is that this is one more tool to try to keep people from getting second infections and to reduce transmission in the community. And so we recommend that everyone, regardless of whether you've had COVID, we recommend getting the vaccination. For people who've had confirmed COVID, it's an option to wait until 90 days after your initial infection, especially in these times when we have limited supplies of vaccine. Probably you've heard of monoclonal antibody therapy that's being used for people with elderly people and people with high-risk medical conditions. If they develop symptomatic COVID, it's one of the options to receive as an outpatient to prevent proceeding to get serious illness requiring hospitalization and ICU care. And similarly, among people that are hospitalized with COVID, one of the treatment options is convalescent plasma. Those both have antibody preparations that hopefully are going to bind with the virus and reduce the severity of illness. But they also may bind with the spike proteins that we develop after receiving the vaccine. So the recommendation, if we've had monoclonal antibodies or convalescent plasma, the recommendation is to wait until 90 days after those treatments to get our vaccination. If you've had a known recent close contact to a person with COVID, it's possible you may be incubating the virus, and you may be, we would recommend you quarantine at home until we're sure you're not going to develop COVID. The recommendation, if you're quarantining at home, is to finish out your quarantine period before going to get the vaccine. The concern being you might be developing COVID and might become infectious to other people. If you're a resident in an assisted living or a residential care facility, then it's people who are going to become doing the vaccinations are going to be in full PPE, and it's okay to proceed with vaccination in that setting. They haven't studied whether it's we get a good immune response to the COVID vaccine if we've had other vaccines recently before or after the COVID vaccine. So the recommendation is try to avoid getting COVID vaccine within 14 days of another vaccine. In some circumstances, people come in and they've had like a flu vaccine or a Shingrix vaccine 11 or 12 days before, but it's very hard for them to get another appointment. So we may decide collectively to go ahead and proceed with the vaccination, even though it hasn't been fully studied. It's awful hard for some people to come back to get the vaccine. So we deal with it on a case-by-case basis. There are very few underlying medical conditions for which a person shouldn't be vaccinated, and the primary ones an allergy to the vaccine or to a vaccine component. There were people with immunocompromising conditions and people taking immunosuppressive medications in the trials, but there is not, hasn't been adequate study to say how good a person with those conditions responds to the vaccine and how well they develop protection against the virus. So people with those conditions should be aware that we can't say with certainty how well they'll respond, but otherwise we're happy for them to get the vaccine because they're also at high risk for severe illness from COVID. But just at this point, there's a lot to learn about the vaccine. The trials didn't include pregnant women. So there's not a lot of data on how the vaccines affect people who are pregnant or women who are pregnant or women who are breastfeeding. These are not live virus vaccines. So I think the general feeling of experts is that it's likely very safe for a pregnant woman or a breastfeeding woman to get the vaccine. We give other non-live vaccines like influenza vaccine and Tdap vaccine routinely to pregnant women, and we know those do not cause harm to the fetus or to the baby. And we give flu vaccines to babies starting at 6 months. So probably safe, but they haven't studied it to say with certainty that's the case. So if a woman's pregnant or breastfeeding and then she's in a high-risk group, for example, a healthcare worker, it's a personal decision, but she may want to talk to her medical provider and then decide whether or not she wants to get vaccinated. Again, we also know that pregnant women are at increased risk for severe COVID. So it's a trade-off. Common side effects may have local effects where you get the shot, commonly pain and swelling. And then you may get general side effects like fevers, tiredness, chills, or headache. In the trials, about 80% of the people who received the vaccine reported one or more side effects. Only about 1% of the people who had side effects reported they were severe enough to interfere with normal daily activities. So while it's not uncommon to get a side effect, almost always they're very mild. There's some indication the side effects seem to be more prevalent with the second shot than the first shot, and more commonly reported by younger recipients than older recipients. that most of the people we have seen have had very mild, um, uh, reported mild side effects for 1 or 2 days, and then they're fine, or and many report they absolutely felt fine with no side effects. There's a rare chance people can have a severe allergic reaction. These severe allergic reactions usually occur within a few minutes to an hour after getting the dose of vaccine. Earlier this month, the CDC published a report in MMWR on the first 3 weeks rollout of the Pfizer BioNTech vaccine. And they noted 21 cases of anaphylaxis after nearly 2 million doses. So about 11 cases per million doses, or 1 case per 100,000 doses. So those are very, very low rate. The odds are very much in your favor that you're not going to have a severe reaction to the vaccine. 71% occurred within the first 15 minutes. All but 1 occurred at the first hour after vaccination. And the majority of the people who experienced anaphylaxis had a history of allergies or allergic reactions. So the recommendations for vaccinators is: 1, people with allergies get watched for 30 minutes. And we all have an emergency kit with epinephrine available just in case. It's been interesting to how, I'm sure you're aware that we all wish there was a lot more vaccine than we currently have available, and it's hard to understand all the tiers that have been prioritized to receive the vaccine. The state has the Alaska Vaccine Allocation Committee, which is composed of a large group of medical experts and an ethicist that worked on developing these tiers for Alaska. And they put a lot of time in developing this, but again, it would be nice to have a simpler system that was easy to understand. So here's where we are. Long-term care facility residents and staff and hospital-based frontline healthcare workers were the first to get the vaccinations. There's been a delay in getting the system set up to do the long-term care facilities, but I think that actually they've made tremendous improvement in the last 2 weeks. And the hope is over the next 2 weeks, almost all the residents and staff in those facilities will have the opportunity to get vaccinated. Many of the residents are accepting vaccination. We'd like to see more of the staff accepting vaccination. Tier 2 is also open for first frontline EMS fire personnel, community health aides and practitioners, healthcare workers who are doing vaccinations. Tier 3 is open for other healthcare workers. And then recently, the tier phase 1B, tier 1 for people 65 and older opened. And that's pretty much where we are. We're waiting for enough vaccine to open for frontline essential workers, people in other congregate settings, in homeless shelters, teachers, a whole wide range of people we want to get vaccinated, but waiting for the vaccine to become available. My understanding is all the vaccine for January has already been booked for delivery, and Sometime soon we may hear about how much vaccine we'll get for February. There's some rumors it's not going to be a huge, maybe even the same or less than January, but I hope that's not the case. It's been very confusing for some people how to schedule an appointment. I don't know the perfect answer. COVIDvax.alaska.gov is the state's primary website that lists all of the vaccine providers who have signed up to administer the vaccine. The PrepMod site, myhealth.alaska.gov, is limited to the providers that have signed on to that system for scheduling vaccine appointments. But I think it seems to be much more convenient to use. The state's added this phone number, 907-646-3322, to call and leave a message, and then someone will call you back and help you schedule an appointment. And I think that's been a big help for many people. This website called AnchorageCovidVaccine.org, I think came online this weekend, and probably that's to me, it makes it very easily to see what sites currently have vaccine for different days and how many appointments they have available, which vaccine they're available. So I think that's probably the most user-friendly site that I've seen. And it has the link to get to the center to try to schedule your vaccinations. The vaccines are being provided for free. I think at the health department, our vaccines, we don't charge an administration fee. And I think that's true for many other sites, but some providers do charge an administration fee. Why get the vaccine? If you get the vaccine, one, you reduce your chance of getting sick, your chance of needing hospitalization, developing severe complications, and even death. We recognize that many people likely will never have to deal with those issues, but we can't predict who's the unlucky one in all circumstances who's at greatest risk. Getting vaccinated, while it helps protect you, it protects the people around you, your family, your friends, your coworkers. If you're a healthcare provider, it helps protect your patients. And there are many other people at risk in our community. If we get vaccinated and don't require hospitalization, it takes some of the burden off our healthcare system from being overwhelmed. And if a large number of people get vaccinated, it makes it very hard for the virus to jump from person to person. This means we can stop the spread quicker and get a little closer to ending this pandemic. A few final things to remember. One, protection from the vaccine is not immediate. Seems like we get some protection around 10 days after the first dose of vaccine, but it really is until 1 to 2 weeks after the second dose that we get maximum protection. And 95% is not 100%. No vaccine's 100% effective. We know the vaccines are very effective in preventing symptomatic COVID, but we don't know if how well it protects us from getting asymptomatic COVID, and if it will protect us from developing an asymptomatic infection and transmitting it to other people. So, in addition to getting vaccinated, we still have to practice the standard playbook to keep from keep ourselves safe and keep the people around us safe, including wearing a mask, staying at least 6 feet away from others, avoiding crowds, and following all the quarantine guidance that we're so familiar with. And finally, my thanks to all you are doing and all you've done to help us get beyond the pandemic. And I guess now we can, I'm happy to help with some questions.
All right, thank you very much for putting that together for us. Now I would like to open up the floor for questions. Please, if you have a question, please submit it to either the Teams chat or if you are in the Teams meeting, or to Facebook comments, and we will keep an eye out for those. We do have someone monitoring the chat who will tell us if you have a question for us to answer. I do have some prepared questions if we don't get any, so we'll give it a moment, see if anyone has anything they would like us to ask first. Okay, I'm not seeing anything right away, so I'm going to go ahead and start with the questions I have prepared, and at any point, please feel free to add your comment. We will get to it as soon as we're done with the one we're working on. So we kind of explained a bit about what mRNA is, but how is this type of vaccine different from vaccines that were developed in the past? Why was it so much faster to produce?
So first, I should confess that I've seen some of the questions. So let me show this figure. This summarizes. We know there are multiple types of multiple COVID vaccines being developed. The one we're using now uses the messenger RNA that codes for the spike protein that gets into cells and causes the body to produce the spike protein, and then our immune system reacts against it. There's another option under development is using a non-infectious adenovirus vector to a non-harmful adenovirus vector that again enters into cells and causes the body to make the spike protein. And other vaccines are just using the spike, have purified the spike protein and inject the spike protein, all working to get our immune system produce the vaccine. Unlike some of the vaccines do take a long time to produce, like influenza vaccine is commonly the different strains of influenza to be put into the vaccine are grown in chicken eggs for several months to get a large quantity of the virus, and then the virus is inactivated and used in the vaccines. Many of the other vaccines don't take a long time to produce, but usually it's 5 to 10 years of research and trials before a vaccine's ready to be approved for general use in the population. COVID presented an emergency situation, and they were able to accelerated both the creation of the vaccine and the trials to try to get something available to try to help protect people and stop transmission.
Okay. Next question leads actually very well into that, which I'm actually skipping one on our list that I showed you. And You mentioned that these vaccines were accelerated, and in this case, they have an FDA Emergency Use Authorization rather than an FDA Approved status. What is the difference between the Emergency Use Authorization and Approved status, and why was it used in this case?
So in some circumstances where there's a great importance of getting a vaccine available in this pandemic situation, we didn't have time to wait 5 or 10 years to go through the whole process that would normally be required for a full vaccine approval and licensure. So the FDA has the ability in extenuating circumstances to issue an emergency use authorization to allow a vaccine to be used while we're under an emergency declaration, which we are at the current time. So, again, it didn't happen overnight. It took about 9 months, almost 9 months of development and trials, 3 stages of trials before FDA was able to review the data and say that it was considered to be of benefit and safe to use.
Thank you. I feel bad for taking you out of order. So we'll jump back to the previous question, which was submitted by one of our comments on social media. Should a person who is receiving the vaccine isolate or quarantine for any length of time due to the vaccine containing live components?
So these vaccines do not have live virus, and they don't make live virus, and so no one needs to quarantine after getting the vaccination, unless you've had close contact to a person with the real virus, and just like we would tell you, even if you hadn't been vaccinated.
Fair enough. Okay, so proceeding in order. How long is it normal for side effects to last after getting the vaccine? And if my symptoms last longer than that, what should I be doing?
Most people have side effects for 1 to 3 days after getting the shot. The recommendations or the reports from CDC seems more people report a side effect after their second dose than their first dose. But again, I think most people get their side effects. They may have a sore arm beginning 1 day after the vaccination, but usually over the next 24 to 48 hours, it's gone. And I'm not aware of anyone that we've seen at the health department who's had a reaction longer than 3 days. If some people get a little redness or swelling where they get their shot, that's okay. But if it seems to be getting worse more than 24 hours after the shot, more redness and swelling, I think you'd be a little concerned about a possible infection at the injection site and need to get it checked. And again, if your side effects are worrying you or not going away, the CDC, the trials indicated some people could have side effects up to in the first week. So if it's longer than a week or longer than 5 days, probably should check with a healthcare provider.
Okay. Next question. If I do present an allergic reaction after getting the vaccine, how will I be treated for it? And how long should I monitor for a reaction after getting the vaccine?
So I mentioned this MMWR report. 15 of 21 cases developed their allergic reaction within 15 minutes, and 20 of 21 developed it within 1 hour. And almost all of those people had a history of allergies. So we're gonna, if you have any history of allergies, we're gonna ask you to sit around for 30 minutes. But if something came on after that, say you started to get short of breath or notice swelling of your mouth and tongue, we need for you, and you've left the clinic, then you need to go straight to the ER or call EMS. The standard treatments and for people who are having anaphylactic reactions, injection of epinephrine. At the health department, we have EpiPen auto injectors we use, and also have epinephrine for injection we can draw up and administer. That always is available where we're doing vaccinations.
Okay. That actually covers the next question on my list. I do see that we have a comment incoming, so I'm going to go ahead and wait for that and see if it pops up here. Sorry, there's a little bit of a time delay. So just the clarifying question while we wait for that to come up. So those supplies to treat any allergic reactions will be on site at all distribution centers?
That's been very highly recommended by the CDC and the state immunization program. And I know it's always available at our health department clinics.
Okay.
And in addition, we have a big team of very talented public health nurses and other healthcare personnel at the health department that I'm pleased to work with, that really know how to handle these types of situations.
Okay. Well, it looks like our guest is still typing, so I will keep an eye out for that comment and go on to our next question while we wait, which is there any evidence as to whether the current vaccines that are available are effective or not effective against the new emerging virus strains that we're seeing? And if not, can we expect more information on that topic anytime soon?
I think I threw that one in on this slide. So I'm sure many people are reading about these new variants that are being identified in places like the United Kingdom, South Africa, and the most recent one I heard about were some travelers to Japan who'd come from Brazil who had a new strain. The concern is that these new strains, or these variants, RNA viruses mutate and things over time, and things gradually change. And will our vaccines that target the spike protein still work if a mutation causes a slight change to the spike protein on the virus? And the B117 variant is the one that has spread like wildfire in the United Kingdom. And the initial studies so far seem to indicate that they expect the vaccine will work well against that variant of COVID-19. And I've heard similar things about the variant from identified in South Africa. And I think there's not yet certain whether what I haven't seen any official recommendations about the newly identified variant that was picked up on the travelers from Brazil. All along, our state public health lab has been working with researchers at UAA and UAF has been genotyping a small number of COVID-19 isolates. Um, but since these variants came to attention, pretty clear everywhere that we need to be doing more genotyping to looking for these variants before they become widespread. There's some predictions that the B117 variant, because it spreads so easily from person to person, may become the predominant strain circulating in the United States over the next couple months. So want to make sure we're ahead of the game, and if we detect a variant that the current vaccine is not going to work well against, then there's the potential to produce or develop very rapidly, just as we do with influenza strains, another vaccine or a combined vaccine to target both the regular COVID and the variant strains to try to keep everybody protected. It may be that over time we're going to need, just like influenza, the strains that are included in the vaccine change from year to year. It's possible that we might need to get ongoing yearly vaccinations that better cover the strains that are currently circulating.
Thank you. Now we have two questions that came in over chat. The first is a comment on vaccine appointments, which is that they're currently by appointment only, and our guest is wondering if there is any sort of process in place to stand by in case someone misses their appointment in order to receive the now available vaccine dose.
I don't know if the state covidvax.alaska.gov or myhealth.alaska.gov sites allow people to sign up for waiting lists anymore. I know there were people on waiting lists, and then that got to be difficult to handle. I know some clinics are allowing people to sign up on a waiting list, and they contact people if there's an opening to come in to get the vaccine.
Okay,
there's also discussion of mass vaccination clinics like we saw at the Alaska Airlines Center, and then at the fairgrounds in Matsu, and we're waiting to see how much vaccine we actually may have available for February, but I think we'd love to see it progress beyond vaccination by appointment to having the capacity to take large numbers of people and vaccinate them without having to deal with the hassle of using the appointment system.
Okay, and our second question from the same user, does the vaccine have to be used before it warms to a certain temperature?
It has to be, I don't think it can be warmed beyond room temperature. There's a period of time after it gets reconstituted and the vial is punctured in which the vaccine has to be used. And I don't know the figure for the Moderna vaccine. I think it's after the Pfizer vaccine, within 6 hours after the vaccine is reconstituted and brought to room temperature, all the doses have to be administered.
Okay, and thank you very much. We are actually almost out of time, so I'm going to ask my final question, which is, of course, where is the best place to find up-to-date information on COVID and the vaccine process for Anchorage?
So these are some of the websites that I could come up with. I really like this AnchorageCOVIDvaccine.org site gives you a easily understandable picture of which vaccination sites have vaccine and appointments available, and that covers statewide. Other websites, the municipality's coronavirus response site, and the state of Alaska, COVID-19 in Alaska has a great deal of information, including the covidvax.alaska.gov and myhealth.alaska.gov sites.
All right, well, thank you so much for joining us. That's all the time we have today. Thank you, Dr. Chandler, for preparing your presentation and talking with us. And thank you again, everyone, for joining us. We will be having another program in this series next Wednesday at the same time, 7 p.m. And that discussion will feature public health nurse Samuel McElwee, and we will be discussing more about vaccine appointments and what to expect at those appointments, as well as more information on symptoms and any precautions that should be taken. Once again, Dr. Chandler, thank you so much for joining us, and to the Anchorage Health Department for helping us organize this event. As always, I would love to thank everyone for joining us for this program and wish you all a wonderful night from the Anchorage Public Library. Thank you very much.
Many thanks.